All right. Well, thank you, everybody. Welcome. We're honored to be invited to present. I'm Susan Torella. I am the clinical lead here at PBSC, and we're going to be sharing a little bit about our suicide prevention model. Our title of our presentation today is Delivering a Behaviorally Intensive Suicide Prevention Model. I'm joined by Shannon Carey and Lauren Firth, who are BCBAs, and I'll talk a little bit about each of their experience within the organization a little bit later on today. As Katie mentioned, we are an ACE provider, so we do have a couple keywords embedded within our presentation for you guys to take note of.
Sorry, Susan, just to interrupt, we can actually see the notes as well.
You can see the notes? Okay.
Yeah.
Let me stop sharing then. Sorry, guys. Let me try that one more time. Okay, hopefully that's a little bit better. Perfect. And then I'm just going to pull up my notes separately. So apologies if I look off to the side. Just want to make sure I cover everything. So as far as today, most of you guys are aware of the content. I would assume you chose to sign up for this presentation today, but just as a little bit of a warning, our presentation does contain content about suicide as well as suicidal feelings. We do understand that this can be surprisingly triggering for some people. Sometimes you don't realize it until you're in the midst of it. So if you need to take a break, step away from the presentation, we can't see, so we will not be offended. And as Katie mentioned, this is being recorded. So if you miss anything, you can come back and watch it at a later date at your own pace. Just be mindful of that. Also, as another disclaimer, it's really important to note that while we're going to be discussing the use of our intensive suicide prevention model today, this is not intended to be a formal training on how to deliver it. The purpose is to really highlight the research, a lot of the gaps in the research, and really the need for this type of a model, as well as then highlighting some of the elements to it. And in addition, some of our outcomes that we've had. A little bit of who's in the room. So if you wouldn't mind just using the chat function, we like to know who it is that we're talking to so we can pitch things. We will at the end have a chance for some Q&A, and we'll be using the chat function for that as well. But if you wouldn't take a moment to note what your role is. So if you're a PBS practitioner, a behavior analyst, a parent, social worker, teacher, therapist, you have a better sense of who's here than I do, as well as your experience with suicide and suicide prevention work. While you're doing that, I'll tell you a little bit about myself. So I mentioned I'm Susan Torella. I am a board certified behavior analyst and a licensed behavior analyst. I'm the clinical lead at Positive Behavior Support Consultancy. So I oversee all of our clinical practices here, specifically, obviously, our suicide prevention work. And I've been practicing in the field of behavior analysis since 2000. So I've worked not only in intensive community-based services like PBSC, but also in homes, in schools, and in interdisciplinary centers. So that's just a little bit about my background. As far as the chat, it looks like we have a range. So we have behavior analysts, practitioners. It looks like mostly behavior analysts and practitioners, and some clinical leads, mental health leads. A lot of PBS practitioners, it seems. Welcome. We have a learning disability nurse. We always like those. We have some of them on our team as well, a psychologist. So it looks like it's very heavily clinician focused. Don't really see any families or consumers themselves from what I gather. Apologies if I've missed anybody off, but appreciate that. And it looks like a range of types of services. So that's good for us to know. And apologies, just need to hide the chat now. Okay, so for the objectives for today, we're going to tell you a little bit about who we are and what we do. I think it's important just for context, and how we started working within the field of suicide prevention. We're then going to highlight the statistics, specifically looking at the statistics in the autistic community. discussing research on suicide prevention models, again, linking those specific to those in the autistic community. And then from there, we're going to provide an overview of our model, and that's called the BICS suicide prevention model. And we'll talk a little bit about what that actually means. We'll talk about some case studies and then future directions for our work. So who is PBSC and what do we do? We are a consultant organization with over 10 years of experience. So we were founded in 2007 by a behavior analyst / clinical psychologist. We provide positive behavior support to individuals across a range of settings. We work in homes, we work in care homes, hospitals, and in schools. And we support those with learning disabilities as well as those who are on the autism spectrum. And you're going to hear us using language around about autism in a variety of different ways in this presentation. We tend to tailor how we talk about the individual based on their preferences, as we're realizing now more than ever that we have to be more sensitive and include those types of thoughts in decision making. So you'll hear us saying, you know, people in the autism community, people who are diagnosed with autism, autistic people, interchangeably throughout, just because we will use the language that our consumers want us to use. So when we're talking about BICS, that stands for our behaviorally intensive community support model. And that's the 5-stage model that we've developed that we use with a range of clients. So this is not just specific to our suicide prevention work, but it is the foundation for that work. Within these 5 stages, we first start with matching. So it's making sure that we are the right service at the right time that meet the needs of both the individual and their network, because we are a short-term piece of work. So we want to make sure that there are sufficient people around the individual that can learn from us and kind of carry on that torch when we fade out over time. So a lot of what the work that we do is direct work as well as upskilling the people around them. We then will engage a little bit more with the network to make sure that they are ready to engage with us and really get a sense of their level of need and that of the person that we're supporting. Our understanding stage is very similar to what you would think of as within like an assessment stage, where we are completing functional behavior assessments, motivational interviews, looking at quality of life indicators, value-based assessments to get the big picture around what the individual's wants and needs are, as well as then to start to pinpoint those behaviors of concern that they've been referred for, how they're socially valid to measure and to implement behavior change procedures, and then setting specific goals, all based on the function of the behavior and the analysis that we conduct. Our delivering stage is where we are working one-on-one with the individual, as well as their parents, their carers, and those in their network. We're setting specific goals to increase their self-advocacy and communication skills, to work on their coping skills and flexibility, and really just developing skills that they'll be able to sustain long-term when we start to fade out. Once those goals are achieved, we then move into our celebration stage, where we are, shouting out those achievements and those accomplishments, and then passing the baton back to the network, the parents and the carers, making sure that they can maintain skills. We then will do follow-ups for our traditional BICS services. We'll do a 6-month check-in. When we talk about our BICS-SP model, we do a couple more check-ins just to make sure, because we realize that readmittance is more likely for those who are in that suicide prevention model. So this brings us to our first sign-in code. Our first sign-in code for you to note down is intensive. Again, take note of that. At the end, I'll put in a link to a form that you guys can use, or Katie will help with the admin side of that. Okay, so now we're going to be talking a little bit about suicide statistics in the autism community. In the past couple years, PBSC saw an increase in referrals where behaviors of concern were related specifically to suicide attempts or ideation. And this then led us to explore a little bit more the prevalence of suicide in this community. And so we've, of course, first looked to the research. So it's only really been, unfortunately, in the last 10 years where we've started to see evidence on the rates of suicide within the autism community. Hervikoski and colleagues in 2016 identified that people who were autistic were 7 times more likely to die by suicide compared to the general population. So that's a really high number. Further studies have looked at the prevalence of suicide ideation and suicide attempts. So Headley and Ilyarovic in 2018 did a systematic review where they looked at 13 studies across a 10-year period. And within there, they found a wide range, anywhere from 1 to 35% of autistic individuals were attempting suicide. Additional studies have been done. So Cassidy and Rogers were looking at prevalence of suicide ideation, and they found specific in the autistic community that 72% of individuals were likely to think about suicide and make plans around suicide, versus where in the neurotypical population, that's only about 17% of individuals. And then for those who are actually attempting suicide, Ivy and Stevenson found, again, a wide range in statistics, anywhere between 1 to 35% of individuals on the autism spectrum may attempt suicide, compared to 4.3% is the statistic within neurotypical adults. And I just want to take this moment to kind of talk a little bit about what we mean about suicide ideation versus suicide attempts, because that's a really important thing that we highlight within our work. And I know we'll talk about this again later. Within suicide attempts, that's actually when people are making those attempts. So engaging in behaviors that would result in their own death with the intent to cause their death. Versus suicide ideation is having those thoughts and feelings and making a plan. So it's not just thinking about, oh, what would happen or how would people feel? It's saying things like, I want to die, and then also trying to decide how that would be completed. And then as far as looking at additional research, Kirby and colleagues in 2019 published a 20-year longitudinal study on suicide trends in the autism community. They were looking at a statewide autism facility. They really did see that over time, there was an increase in prevalence. So as people got, as time progressed within the study, within the studies published, they saw an increase. They also found that there was higher rates of people who were identified as female, who were more likely to engage in either suicide ideation or suicide attempts, and that there was an increased risk for autistic young people. And we find that similarly within our work, whereas if you think about the statistics around autism and gender, that it's I think on an average, it's about 4 times more likely in males versus females, where we'll share some of our statistics later. We do see a higher prevalence of female, and then we're also looking at non-binary individuals as well. So obviously it's a big concern. We saw it within our community of those being referred to us, as well as just looking at the literature. The literature supports that there is an increasing need to support autistic people around this behavior of concern. So that led us to then doing further research on, okay, how can we help them? What types of suicide prevention models are evidence-based that we can incorporate into our BICS 5-stage model? So NICE guidelines does exist. Unfortunately, it's not specific. Autism and suicide, honestly, just suicide in general, is just poorly understood, and there's minimum research and evidence-based around interventions. Studies have typically used small, non-representative samples. They lack validated measures, and unfortunately, they fail to explore risk or protective factors. And when we say protective factors, we're really specifying those reasons for living. And suicide prevention tools in general just need to be individualized more to the autism community. So there are 2 studies that are underway looking at different types of approaches to treating suicide in autistic individuals. All the evidence really is looking at, unfortunately, though, more general population statistics or interventions, or the strategic level, not really at the individual level. So these studies are fairly unique. The first one is by Autistica and the National Institute for Health Research. And they're looking at using remote support and a self-referral system to support autistic adults to create safety plans. And then they're using post-consultation follow-up to look at the impact of the safety plan. And they're hoping to conclude their research actually within this month, is where they are in stage 3 of their research. The second study underway is at a university in Amsterdam, where they have used dialectic behavioral therapy to treat the symptoms of suicide in individuals with other types of mental health conditions. So like borderline personality disorder. So now they're applying that DBT to looking at reducing suicidal behaviors in the autistic community. Again, this is underway. They're hoping to publish their preliminary findings in 2024. So that led us to wanting to find just other types of evidence-based research, specifically on suicide, and really taking out the autistic population's needs, because we felt that we have the skills within our work to individualize to that population, but we really wanted evidence-based intervention that had research to support it. And that's where we found PROSPER. PROSPER is the proactive reduction of suicide in populations by evidence-based research. It was founded by Kent Corso, who's a behavior analyst and a clinical psychologist in the US. And they have found that it's been derived by research on suicide prevention with both US military and civilians. And this started because they found the US Army suicide rate to surpass that of the general population back in 2008. So again, similar issue was happening back in 2008. There was a higher risk, just like we're seeing right now within the autistic community. And they have found that effective crisis response planning has been able to reduce suicide attempts up to 76%, which honestly is pretty astounding. They've also found that brief cognitive behavioral therapy has reduced suicidal behaviors by 60% compared to treatment as usual. So through the PROSPER model, they've been able to assist clients with suicidal symptoms in a collaborative, empowering way that's anchored in the values and priorities of the individual. And we found that aligned very well within our model and the values of PBS and our PBSC company. Through developing effective crisis responsive plans, as well as delivering at a high standard of care, they've been able to develop and identify different coping strategies and skills, establishing a stronger sense of meaning for life by addressing the underlying ambivalence that is really at the root of individuals who are suicidal, and really addressing the reasons for living and helping to build up a more robust reasons for those aligned with people's values. And so within this collaborative approach, they have been separating suicide from mental illness. So really thinking about it as a behavior that we can change systematically, thinking that this behavior is within the individual's problem-solving repertoire because they're the expert and we really want to tap into their values. Working alongside them to understand suicide from their point of view, making sure we're reinforcing help-seeking behaviors. Unfortunately, when we think about other more traditional interventions, it's not always reinforced. Sometimes it's punished by more intrusive supports that are unwanted. So really making them understand that not only is help available, but it's effective and it can work for their needs. Also, this is a sensitive topic, we've mentioned that, but as practitioners, we are not afraid to address it and have those difficult conversations with those that we support. And ultimately, our goal is to address any type of distress by deactivating the suicide mode in the individuals we work with.
Thank you, Susan. Perfect. Yeah, so now I'm just going to spend a bit of time talking through some terminology and what we mean by different terms. So firstly, thinking about what is suicide. So suicide is a state of feelings of hopelessness, burdensomeness, powerlessness, and thwarted belongingness. And as Susan mentioned, it's a state of ambivalence. So if an individual is talking with you about suicide and about having those thoughts and feelings, we can infer that there is a part of them that wants to solve that situation or that wants support, even if only a small amount of them that does potentially want to live. And it is also a solution in the problem-solving repertoire of the person. So an individual is suicidal because they don't know how else to alleviate their suffering. It's equally as important when we think about suicide to think about what it's not, because there can be some quite unhelpful terminologies that are kind of universally used. So suicide is not a cry for help. It's not attention seeking, manipulation, a threat, self-injurious behaviour, or behaviour that can be boiled down to calculating risk factors. So it's just important to think about the kind of terminology we're using when we are supporting someone, or even just speaking about suicide. So we wanted to spend some time just really differentiating between different terms. I think they can get misconstrued, and it's just, yeah, really important exercise. So first of all, differentiating between a suicide attempt and a non-suicidal self-injury. So a suicide attempt is intentional, it's self-enacted, and it might result in injury. However, the key thing is that it's with any amount of intent to die. Whereas with non-suicidal self-injury, it again would be intentional and self-enacted and may or may not result in injury, but it's with no intent to die. So the key difference there is whether there's that intent or not. And that's why it's so important that we don't just look at a behaviour and kind of assume whether it's a suicide attempt, and we actually dig deeper and look at what is that intent there. Equally, we spend quite a bit of time in our process differentiating between suicide ideation and death ideation. So suicide ideation are thoughts of ending one's life or enacting one's death, whereas death ideation are thoughts about death without that suicidal or self-enacted content. And the reason that it's really important that we differentiate between SI and DI is because SI does and can reliably lead to suicide attempts, whereas death ideation doesn't reliably result or lead to suicide attempts. And suicide ideation is associated with significantly higher levels of psychological distress than death ideation as well. And just to note that people can fluctuate between both suicide ideation and death ideation, and fluctuations can happen in a matter of minutes and hours as well. So we just thought we could take a couple of minutes just to do a brief exercise. So we've got 5 different kind of scenarios or quotes, and what we wanted to do is just pop them up one by one and just see, based on hearing about those definitions and the presentation so far, if people would feel confident and comfortable enough just to write in the chat whether they think each scenario is death ideation or suicide ideation. So the first one we've got is planning my death. Do we think that's death ideation or suicide ideation? Perfect. Thank you all for participating there. And yeah, everyone's getting that bang on. So yeah, it's suicide ideation because it's thinking of suicide and it's that planning element. The next one is thoughts of death or dying. Amazing. Yeah. Thank you, everyone. Yeah, again, spot on. It's death ideation because it's thinking of death. And then we've got the third one, which is thinking about how I might kill myself. Great stuff. Thank you all. You're very speedy with these. Yeah, exactly. It's suicide ideation, thinking of suicide. The fourth one is imagining I will play a part in causing my death. Yeah, we've got this one, I think is a bit trickier. And we've got some mixed responses there. It is suicide ideation. And I think the key part there is because when they're having thoughts of death, they're thinking about them playing a part in their death. So that's the part that makes it suicide ideation rather than death ideation. And then the final one we've got is, what would people say if I died? Thank you. Yeah, everyone's really good there. So that's death ideation, because it's thoughts of death without that self-enacted suicidal element. Perfect. Thank you all there for your participation. So basically, once we know that a person is experiencing suicide ideation, our first goal is to decrease their distress, and that is obviously the most important goal. So we often refer to that as deactivating the suicide mode or switching the suicide mode off. But equally, we also, as well as that being a number one goal, we also want the person to know there's help available, and we also want to help them identify reasons for living. So this is about supporting people to think of what is important to them in life, what do they have to live for. And as Byron's research found, a stronger sense of meaning in life is significantly associated with lower emotional distress, less severe suicidation, and better functioning across multiple domains in life. So that reasons for living aspect is equally really important, and you'll see us touch on that quite a bit throughout the presentation. Perfect. So given, as Susan displayed earlier, the pretty much non-existent evidence base for prevention of suicide in autistic adolescents and young people, we've used, as Susan mentioned, the PROSPER evidence-based behavioural science model as our clinical framework, and we've integrated it within our existing BICS model, which was the 5-stage visual that you saw earlier. Before we jump into the 5 stages and what it looks like in the BICS suicide prevention model, I did just want to mention that it is a collaborative model. It is a collaborative approach. So when we're talking about this model, it is done with the individual and everyone around them, and that includes the network of support. So in PBSC, we work with everyone supporting the individual or involved in their life. So that, for us, key kind of people we work with tend to be families, social care, key workers, CAMs, school staff, and respite staff, just to give you an idea of who we are implementing this model alongside. So we've already touched on the 5-stage process. So the key point of this slide really is just to highlight to you and the difference really between our typical BICS model and our BICS suicide prevention model. And the key difference really is that with our BICS suicide prevention model, because of that high level of risk, we don't want to spend kind of 5 weeks doing an assessment before we provide any intervention. So the key difference with BICS suicide prevention is that we actually front load our support at the start to mitigate that risk by doing our understanding and delivering stages together. And we also up the intensity and frequency of the input for the first 6 weeks. So traditionally, we'll work with someone for the first 6 weeks for maybe 2 days a week, and then we might drop it down when we are just in the intervention and we finish the assessment part to 1 day a week. So that's just to give you an idea of intensity. So the first stage of our 5-stage process is matching. So we have developed a matching tool for all the young people and adults we support. And the aim of this matching tool really is to understand what is the person's needs, what do they want support with, what would they like to achieve, who is the network around them, are they presenting with suicide ideation and suicide attempts, and who are in their professional network. And essentially, we're assessing our goodness of fit and whether we're the right service. Another key part of the matching tool is looking into biological and psychological reasons for maybe the suicide attempt or ideation, because we do recognize that we cannot apply this model with individuals where the sole reason or cause of their suicidal behaviour presentation might be due to psychological needs. So for example, if it's a psychosis episode. We do also recognise, as I've said before, that in order for this model to work, we need to be collaborating, because we don't work in silo. It's all about that collaboration. So we would be really looking into at this point as well, who is in the network and how can we support them. Once we've confirmed that we're the appropriate service, we then take time to engage with our client and with the network. So we recognise that suicide is obviously a very sensitive topic, and it's an approach that's quite unfamiliar to most families. Suicide isn't talked about often enough, or sometimes it's not talked about at all. So given this, it is important for us to take time to prepare and fully engage the people we're working with careful consideration. So we want to look at what are their likes and dislikes, what are their preferred forms of communication, how can we mention suicide? Is it something that they openly talk about? And which language is most appropriate for us to use when we're talking about these sensitive topics? And it's really important that we're establishing that rapport and establishing that mutual communication and not shying away from the topic of discussing the suicide or suicide ideation. But it's also a chance at this stage for us to learn from the network about what is their involvement and formulation, what are their roles versus ours, and how can we fit in and be supportive to this network, as well as a chance for us to raise awareness on our model and what we aim to achieve, and to set those kind of mutual goals as a network as well as with the young person. And we do also have a quick profile and risk assessment whereby we look at presence of suicide ideation with the client as well, and measuring that. So then we are coming up to stages 3 and 4. So at this point, hopefully we've established that we're the right service, we've built the rapport or started to build rapport with the person we're supporting in the network, and we've established that they're willing to move forward with us. So at this point, we are, I guess the kind of key aims of our understanding and delivering phase is that we develop a good understanding of the risk levels and of the suicide ideation. And that would kind of lead on to us developing a functional behaviour assessment. So being able to look at what are the triggers, what are the setting events, what does this behaviour of concern look like, what does it currently result in? As well as then looking at formulating a crisis response plan, which we'll look at in the next couple of slides. We also want to be looking at what skills does this person have? For example, do they have any self-regulation skills? Can they identify what triggers might be switching on their suicide ideation? Do they have help-seeking behaviours? And what can we kind of be building on there? And it's also a chance to collaborate with the network on things like that assessment and, looking into identifying any gaps that they've come up against as well. So one of the key documents that we co-produce with the person we're supporting at this stage is the crisis response plan. So the crisis response plan is an individualized form that's created with the person. It functions as a prompt, so it's supposed to be proactively used at the onset of the first warning sign. So the idea is that we're not waiting for this suicide mode to be switched on, but we've got these proactive approaches to kind of support the person beforehand, or just as they start to feel maybe slightly triggered or maybe slightly distressed. And it does differ to a safety plan, because a safety plan tends to be more reactive when a person's already in crisis and focusing on keeping the person safe. So quite often when we come into a network, there might already be a safety plan in place, but they might be finding that it's not enough to reduce behaviour of concern. So what we would do is we would come in and build the crisis response plan with the individual we're supporting, focusing on that proactive approach, looking at the warning signs for them. And essentially, the crisis response plan is supposed to be used, or the end goal would be that the person can use it independently and doesn't need others there to facilitate it. So we would then collaborate with the network to identify ways that we can amalgamate their safety plan with the more proactive parts of the crisis response plan as well. So I just want to spend a few minutes now talking you through what we are talking about when we talk about a crisis response plan and what the key parts of the crisis response plan are. So first of all, when we are developing a crisis response plan with the person, we're looking at warning signs. So we're working with that person to try and identify what are their feelings, thoughts, behaviours and triggers that are happening before their suicide ideation. And it'll vary how much someone has this information to hand. You know, it might need some coaching and support to be able to get those answers. Then we'll be looking at coping strategies. So we will work with the individual to identify, do they have any current effective coping strategies? Or equally, are there any coping strategies that they've tried that are not effective? Because that's equally helpful to know. And the network can be really helpful at this stage. You know, they might have tried some clinical coping strategies that they can tell us about. And we can also use our functional behaviour assessment to guide us here, to make sure that when we are suggesting and teaching new coping strategies, that they are kind of functionally equivalent to meet the person's needs. We would then be looking at reasons for living. So we'd be supporting the person to think about what are their reasons for living, what is meaningful for them. So that might be a relationship, a friendship, it might be a future goal or aim that they have. So for example, a person might say that a reason for living for them is because they want to do a certain university course or a college course, or pursue a certain academic goal. So we might work with them and their education placement, you know, to try and make that happen. Equally, it might be that they want to build more relationships and feel they don't have access to much space to do that. And it might be working with social care to identify community groups for that person. The next part of the crisis response plan is access to social support. So this is where we are supporting the individual to identify who they have in the social network, who they can contact proactively for support. So it might be a family member, a key worker, for example, someone they can trust and who is available. And then finally, we have the crisis support section, which is in a crisis, who can that person contact? And this part usually would have been covered by that safety plan. So this is where we can draw from the safety plan that's already been developed. Perfect. Thank you for your time. And now I'll hand over to Shannon.
Thanks, Lauren. So now we're going to focus on the teaching of skills. So what sort of targets we set for clients and their mediators. So identifying and teaching effective coping strategies is absolutely necessary for any intervention to be effective, especially with this type of work. So target setting and identifying coping strategies should be done in collaboration with the client and the network where possible. Some of the targets that we tend to identify for clients might be around increasing use of independent coping skills, increasing their use of problem-solving skills, being able to independently understand triggers to their suicidal ideation and attempts and how to switch them off. For caregivers, targets might involve things such as being able to also being able to independently identify whether the suicide mode is switched on or off for the client, how to deactivate it if it is switched on, being able to support the individual with their crisis response plan and keeping this a live document, as well as being able to enrich the client's life to minimize triggers. So some of the evidence-based strategies that we focus on with the individual directly might include things like functional communication training. So does the individual have the appropriate means of communication to be able to seek help effectively or be able to communicate their emotions to others effectively? Things such as meditation and mindfulness-based practice. Supporting the individual to define, rank, and manage their triggers. So this might look like supporting the person to rank their triggers from least triggering to most triggering, and then teaching effective self-management strategies for them to implement at each level. Identifying activities and strategies that add value to the person's life, and as such lead to overall improved quality of life, skills building, and problem-solving skills. So to support the effectiveness and social validity of these strategies, we do encourage the person to track their own development and progress with these goals. And we tend to create with them bespoke data collection systems in order to do that. And this helps us to understand when the individual has met criteria on their target. But it also helps us to know when we can begin to fade out. So the criteria for us kind of fading out and closing the BICS suicide prevention model is 30 days, 30 consecutive days of no incidents of suicidal ideation or attempts. So having a look then at caregiver strategies. So some of the evidence-based targets for caregivers might be things such as using behavioural skills training to teach them the key targets within the crisis response plan and behaviour support plan. Being able to support in a crisis, supporting the client to use the skills within the crisis response plan and behaviour support plan through the use of modelling, and being able to fade that modelling and gradually increase their independence, as well as identifying appropriate means of communication for the individual. So maybe the individual needs visual supports or communication cards or emotion cards if vocal verbal language is a bit much when they're kind of going through experiencing suicidal ideation. Supporting the individual with promoting choice. And we do also encourage parents to engage in their own mindfulness-based practice. Obviously, this is a really difficult situation for everybody involved, not just the individual. So it's really important that caregivers have their own self-management or self-regulation techniques as well. So you've probably heard me mention in the last couple of slides the term behavioural skills training. So I just thought I would explain a little bit to people that might not know what that is. Behavioural skills training or teaching is a method used to instruct parents and caregivers and anyone who works with the individual. Behavioural skills training is a combination of both performance and competency with a particular skill or set of skills. So it has four main areas: instruction, modelling, rehearsal, and feedback. And we'll just go through each of them individually. So instruction. So when we're thinking of this in terms of the BICS suicide prevention model, we break down each skill within the crisis response plan and collate this into a protocol, which we then share with the individual themselves and caregivers. Modelling is we're basically modelling each of the skills, sometimes with the client directly if they allow this, or else in vitro for relevant members of the network. Rehearsal, so we have the individual and caregivers practice the skill with the client or with us. And then feedback, so we're just providing feedback on their performance. And these four steps are repeated until the person practicing can perform the skill to fluency, and also for us as well, that we're performing the skill to fluency too. So once our targets have been met, and both the individual caregivers and the wider network have met criteria with these targets, we then move into our celebrating stage, which focuses on developing a transition plan to fade our support. So during this phase, we're celebrating the achievements the client and the network and caregivers have made, and we're documenting these in a bespoke celebrating report with the individual, completing post-outcome measures and ensuring all documents are up to date. We also ensure to engage the network within this section. So there's generally somebody we're handing this over to, and if not, just ensuring that all family members or caregivers are up to speed using the behavioural skills training to be able to be confident enough to implement strategies once we're gone. So following this, as Susan mentioned earlier on, we do complete post-service check-ins. So we have 3 months check-ins and then 6 month check-ins. And this is really for us to get a sense of the maintenance of skills that have been taught, identify whether the individual needs any more support, so see where they're at that time. Do they need to be re-referred to our service, or do we need to be thinking about signposting them to another service if support is required? So we're going to get into my favourite part of the presentation now, which is looking at case studies and kind of more like in practice of some of the work that we've been doing. So this is our most current data set as of January 2023. So we began this model in March 2021, and since then we've had 66 BICS suicide prevention cases that have gone through this model. Some are still active, some of these are closed. The current age range is between 8 and 38 years, average age of 16. And primary diagnoses is autism spectrum disorder. And the majority of referrals we do get are female. However, in the last few months, we actually have had quite a rising number of male referrals, and we've had 8 non-binary as well. So our initial case study, this was an autistic female who was 18 at the time, who had a diagnosis of mild learning disability as well as borderline personality disorder. And at the time of referral, she was an inpatient in a mental health unit due to some of the really high risk behaviours of concern that she had been displaying. A lot of these in relation to wanting to die. So had quite a long history of taking overdoses, tying ligatures, restricting food and fluid intake to really quite severe levels. And then also there were other behaviours of concern as well, such as quite severe self-harm and risky kind of sexual behaviours too. So initially we completed our understanding stage, which is our functional behaviour assessment. And this was able to kind of support us in identifying what the functions of behaviour were, but also then in developing our intervention plan. So at the time, as I mentioned, she was on a hospital ward. So we spent quite a lot of time training the hospital staff, but with the hope of discharging her eventually and finding her a supported living placement. So some of the antecedent strategies were things that might even seem so basic, making sure she had a safe and secure environment. There were lots of things when we came into the hospital ward that we were able to risk assess within like the first few days, you know, such as having long leads or wires in a hospital room where it's supposed to be a secure inpatient setting. And just being like vigilant of those things, or having like your phone charger in your bag where it could be easily accessible to tie a ligature with. Being able to support her with communication, emotional regulation and choice. We began looking at increasing her social timetable. So over time, we were kind of fading her out of the hospital. We'd found a supported living placement and kind of getting her engaged in more community outings and activities. And alongside this, we were then doing our really cool kind of skills teaching program. So really focusing on building emotional regulation strategies and increasing her coping skills within her crisis response plan. We also consulted with an outside sex and relationship education expert as well for some of those kind of risky sexualized behaviors. So just a nice bit of data here, because we all love a bit of data. This was the data that this person was taking themselves. So this was their self-monitoring data, and this was in August 2021. And we were tracking the frequency of behaviors of concern. So this is suicide ideation, death ideation, suicide attempts for this monitoring. And then the use of independent coping skills as well. So as you can see, their behaviors of concern began to reduce. So that's the blue line. And then their coping skills began to increase. They decided they didn't want to take data anymore because we had basically supported them transitioning out of hospital. At this point, they had got a job in a local chip shop, got a boyfriend, had some friends, and had begun socializing. They were 18, so they weren't interested in taking my data beyond this point. But at least we had a nice little bit of data at the time. So some of their coping skills that they were then doing or found really effective and were doing independently were the Headspace app and using mindfulness-based techniques, learning some deep breathing techniques. So that's slow 8 breathing technique, writing notes in her worry monster, speaking to staff who she knew or who she had good rapport with at her new service when she had been transitioned out of the hospital, as well as taking a bath and hanging out with her friends, of course. So the next graph then was just monthly frequency of suicidal ideation and attempts throughout our intervention. This is between the months of August 2021 and January 2022. So as you can see, there was a really nice steady decrease in both of those behaviours of concern. There was a slight increase in October 2021 due to a staffing change when she transitioned into a supported living placement. But it then went in December and January down to 0 level. So we were able to fade out at that point and close. Since we have closed, we've done a check-in to see how she's getting on. And reportedly, she's doing really well. She started a social care course last September, so that's awesome. And is now in a semi-supported living placement. So she's transitioned from the one that we supported her in to a different one. So she's only got a floating support now. So that's like super awesome. So moving on to our next case study, this was a 15-year-old non-binary individual who had a diagnosis of ASD and had been referred to us for having multiple attempts of suicidal ideation and suicide attempts, and had been on a hospital ward as an inpatient for quite a long time when we became involved. I think about on and off for about a year, and of course they were only 15, so it was quite a long time for them. Some of their main behaviours were overdosing, tying ligatures, presenting at train tracks, but kind of engaging in rehearsal behaviours and not actually doing anything when they got there. Ingesting harmful substances, aggression, self-harm, and property damage. So we began with our functional behaviour assessment as always, and then moved into our intervention stage. So with this case, working as a multidisciplinary team alongside caregivers and the individual was the key to success for this intervention. So with us all working as this multidisciplinary team, we were able to support quite quickly the transition from the ward back home. And some of the antecedent strategies similar to the previous case were teaching the hospital staff how to, again, recognize and manage triggers, have a safe environment, promoting choice, increasing communication. This person liked using emotions cards or communication cards, using distraction techniques. But as I mentioned, the key was our skills teaching in this plan. So even though the individual was like super eager to get out of the hospital ward, they were also really anxious about leaving the hospital ward because it had become really secure and safe for them. And they hadn't been out, you know, in a busy environment, especially living in London as well, for quite a long time. So we asked, what is going to make this easier for you? Like, where do you want to start with this community transition? And they were like, oh, I want to be able to go to the park with my friends, because that's what I used to do. So we were like, okay, let's start exposure work or kind of systematic desensitization to the park. So we started there. Initially, it was just so us, parents and the staff on the ward that would use behavioural skills training, until we were able to plan what this systematic desensitization would look like. And then we gradually faded in the individual and were able to transition them to the park and then eventually back home and then back to school. But this graph, so the graph for their exposure therapy work across the months. So the blue line was the number of incidents that occurred, which was, you know, minimal incidents throughout the months. And the pink line was use of coping strategies through the systematic desensitization work, which was obviously amazing as they progressed through and this increased. The second graph here, so this was the frequency of behaviours of concern per month throughout our involvement or throughout our intervention from October 2021 to May 2022. So as you can see, again, there was a significant decrease across the months in behaviours of concern for the individual. And then I just also wanted to add, these were the outcome measure scores from the goals that they had planned with us or that they had chosen to work on at the start of intervention. So our pre and post outcome measure scores are measured as 0 being as far away from the goal as you can be, and 10 being as close to the goal or having met the goal. So for this individual, their 3 goals were graduated exposure back into the community to have a successful transition from the ward back home, identifying and successfully using independent coping skills in place of their behaviours. And the third one was preparing for a transition back into school. So as you can see with each of the goals, the first time round when we, at the initial stages of the intervention, were all 0, and then we got some significant outcomes at the end, and that's self-reported by the individual themselves as well. So I'm going to hand you back over to Susan for the final parts of our presentation.
Thank you so much. So I know we only have a few minutes left, and we did want to see if there was any questions. I thought it would be nice for us just to highlight a few of the barriers that we've identified are listed here. We hope to be able to address these by really ensuring that we have reflection sessions and debriefings in place for our staff, just to support their own well-being, as well as ensuring lines of communication are consistent across the individuals that we support, the consumers, their families, carers, everybody in the network. We really want to be honest early on in our process as far as what's really required from the network, because it's a lot of work, and it also is a change in philosophy. As Lauren identified, there's a big difference between what's in a safety plan and what we expect in our CRPs, and it's a difference of what you're prioritizing, and it takes a little bit more creativity to make sure that we are actively aligning with the values of those that we're working with to move them closer to achieving their goals. And so within that, we work hard to make sure that the mediators are able to and willing to participate with us, because it's really critical to have those key staff in the family engagement. As far as future directions for us, we're going to continue to collate our data. I always get excited by the changes that we see on a broad scale. And so that's something that we want to continue to review. Continue also to refine our processes and procedures. This is something that is still new for us. We've only been doing it for a couple of years, so we're constantly learning and reevaluating. All of the work that we're doing is based on research with neurotypical population, and so it's important for us to tweak it and continue to refine it for the autistic population. Within that, we continue to partner with Prosper. They come and participate in our surgeries. So we hold fortnightly surgeries where we review our cases, and they support us through that, as well as reviewing our training and providing ongoing clinical supervision. One of our goals is to be able to publish some of our outcomes, though, not only on our SP work, but also on our intensive service model. So hopefully stay tuned. And then also just making sure that our clinicians are well supported. Without them, we couldn't be doing this work. And so within that, we are really just continuing to review our post-vention policy and any procedures if and when we would need to implement that. So the sign out code for anybody who's looking for CEUs is ambivalent. That is the underlying clause for many of the individuals we support, and that's what we're always